Hi everyone. For this week, we're doing chapter 12, I believe. It's called Global Quests for Care from the Rutledge Handbook. This is one of my favorite chapters. There's a lot of really interesting case studies in here to analyze, but the basic idea is it's people who are seeking care in a context other than their home country for various reasons. And these are very heterogeneous examples where people are kind of coming from all different places. And so I'll talk through some of the main concepts that I want to make sure everybody gets for this week. All right, so the first case study, just before I go into that, some of the theory is the first case study is about the medical travel in Southeast Asia. And this is the example where patients are traveling from parts of Southeast Asia to other places, like from Vietnam to Malaysia and that sort of thing, to gain access to healthcare that they can't get in their own country or that they don't trust, either for it's not accessible or they've heard stories that it's not good. And in this model, healthcare becomes a commodity. There's a ton of, if you're interested in this, a lot of really interesting research in MedAnthro of people traveling, for example, to India to use surrogacy services, people traveling to do in vitro fertilization from the US to Central America, like Panama for some reason is a big destination for that. Um, and because it's extremely expensive to do here, so you can do those kinds of things somewhere else. There's some really interesting kind of ethical issues that come up with that. Part of them, some of them are addressed in this case study. Other ones, like the use of Indian surrogates for North American white families, is not only that you're traveling and in some ways undermining the local health system, but you're also, using someone else's body and compensating them, but using their body for your health or your family's well-being, I guess, to make babies. Um, so in this model, healthcare becomes a commodity, something that commodities are usually something that some people can afford to access and some people can't, and that's obviously the case here as well. They're also reliant on these public-private partnerships that are kind of a big topic in global health, if you've ever thought or read about that at all. But basically, one of the things that happens in these places that have these public health systems is that the public health system is for rich people and foreigners, and then the private and the public health system is for everybody else who can't afford that. And it can create a lot of challenges for health equity because it's taking away people and resources from the public system. It's also taking away paying wealthy customers from the public system that might help to fund some of the less wealthy patients. So in the chapter, they give the example that in India, for example, there are something like 600,000 um, a shortage of doctors of 600,000 doctors, a million nurses, 200,000 dental surgeons, but 75% of the resources, the health resources, technologies, and personnel are being used by the private system. And this is similar to the public-private school debate, but if people go to private hospitals, like people from that country, because they can afford it, then they're not contributing into the public system. And also, that's the desirable place for doctors to work, for example, because they can get paid better. They don't have some of the challenges that Livingston's, book revealed of, working in suboptimal, where you can't actually give your patients the proper care. So this is one of the challenges of that case study. The next case study is another really interesting one about healthcare along the US-Mexico border, and it looks at sort of transnational strategies to seek care. And interestingly, it looks at families with mixed immigration status, so where there's undocumented family with some children who were born in the US and some children who weren't. So say everybody in the family gets the flu or some, strep throat, and the child who was born there is on Medicaid, but the other child isn't. So they have to, not only spend the time going to different providers, because the one provider that takes Medicare is different than the free clinic for undocumented immigrants. And but they also often have to make choices for the undocumented children that they don't have to make for the other children, and it creates inequalities and hierarchies within families that can hurt their relationships. And the case study kind of looks at the improvisation, like Livingston talks about, of what the families have to do to provide the care, at the reciprocity within the community. So, which is great in some ways and causes challenges in other ways, that the whole community will sort of say like, oh, here's the families with documented kids. Let's see if they have any leftover medicine from the last time their child had a cough or whatever. But then it ends up being like two of your kids, one's documented, one's undocumented, needs to go on antibiotics. So they get the antibiotics and just split them between the two kids, which is bad for the health of both of the children and doesn't really get rid of the problem that the child has, plus leads to antibiotic resistance. So a lot of really interesting examples there as well. And then the final example was of a Colombian migrant in Germany who ended up living for 20 years, basically in like the cellar or the sort of back room of a family in Germany, and never got paid and was basically like a slave to these people. And he wasn't supposed to go outside, he wasn't supposed to do certain things, but he found these small ways to go to the forest and take walks or visit with the neighbors when the people in the house weren't around. And for 20 years, basically didn't try to leave. And well, one of the things that the author does is she's interested in looking at how people make sense of their suffering. And there's this concept that I don't think we've talked too much about in this book, but the anthropology of the good, where people are not just trying to look at suffering, but are trying to look at how people are resilient and how they care for themselves and others, not just the suffering. This is an interesting one, and it's tricky because in this case, the author is trying to make the case that like Eduardo, the Colombian man, was, he basically says that he was paying off his karma based on sorcery, and he also never tried to leave because the sort of known evil was less scary than the unknown evil. And also because he had some things about his life that he liked, like he enjoyed the relationship he had with some neighbors and that sort of thing. But to me, it's hard to justify that as like in any way him being an agent, having any agency over his life, or so I know it's a tricky question to pursue there. So one of the ideas that they bring up here that I want to talk about is this idea of structural vulnerability. And structural vulnerabilities reveal the fault lines that allow whole groups of people to fall through established safety nets. So why a whole population of people, has worse health or doesn't have access to education, or in other ways is like cyclically poor. And individuals and groups are made vulnerable because the economic and political forces and institutions present in their societies don't work for them in comparison to the others around them. So, so it's partly about, you can look at these on smaller scales, and maybe there's communities of poor people where some are abject poor and some are getting by poor, and the abject poor are the more structurally vulnerable. Or you can compare across borders, in which case whole countries are structurally vulnerable as compared to other countries, the populations of other countries. So they're vulnerable to many things, including poor health outcomes. And health is a really good way to measure other vulnerabilities like economic, educational, safety, food insecurity. If you had data from populations and you could just look at infant mortality and life expectancy, that would tell you, you could probably predict a whole bunch of these other structural vulnerabilities that lead to poor health outcomes. So this is an interesting quote that I just kind of wanted to parse out with you, relating the structural vulnerabilities to health inequalities. So this is from Bourgois, who's a medical anthropologist who is a friend and colleague of Paul Farmer's, and he wrote a couple really interesting books, one on Puerto Rican crack dealers in New York in the 80s, and then he wrote another one about people living with HIV in San Francisco. Anyways, he's an interesting guy, but he says an individual's or a population's condition of being at risk for negative health outcomes through their interface with socioeconomic, political, and cultural normative hierarchies. So basically, I'm just going to break them down each sentence because it's kind of a dense paragraph here. But the structural vulnerabilities are basically a population of people who are at risk of negative health outcomes because of where they fit on the socioeconomic, political, and cultural hierarchy ladder, basically. And then he says patients are structurally vulnerable when their location in their society's multiple overlapping and mutually reinforcing hierarchies, and by this he could have just said like intersectional identities or something that's probably more familiar with you all, and institutional and policy level statuses like immigration status or labor force participation constrain their ability to access healthcare and pursue healthy lifestyles. So basically, you're a structurally vulnerable person if your intersectional identity and your status in society in terms of such things as immigration status and where you work in the labor force, put those things together, and that's going to either enable or constrain your ability to live a healthy lifestyle. And so in the discussion board this week, we'll think about what this means and what are some examples of structurally vulnerable populations in our society that you can think of, or ones that come out for you from the examples in the case studies. So I'm going to show you one of the clips that you were asked to watch today is about kidney disease in undocumented migrants. And so in some of the follow-up questions this week, we'll talk on the discussion board and in person on Thursday for the Zoom drop-in about what ways these patients are structurally vulnerable, what's a better way to care for them, and how do we overcome the political barriers to changing the way that these patients gain access to care. And then I'm also asked you to watch 2 clips about healthcare in Thailand, and I want you to think about power, equity, access, resources, health as a human right, and structural violence, which is basically like structural inequalities that lead to physical harm, similar to the way being violently attacked would. Like if your structural inequality leads you to have poor health, that's considered a form of violence. So those are the kinds of questions that we'll talk about in relation to those case studies. And that's all I got for you today. Have a great day.